Labs are pretty distinct for primary. You'll see high serum calcium, both the total and the ionized, which is the active form. Phosphate levels will be low or maybe normal-ish. And here's the crucial part. The PTH level will be high, but it's inappropriately high, given the high calcium.
Inappropriately high, meaning?
Meaning the gland isn't responding correctly. Normally, high calcium should suppress PTH, but here, the gland is just pumping it out regardless. That tells you the problem is in the parathyroid gland itself. You also usually see increased calcium in the urine.
Okay, and what about imaging? Can you actually see the problem?
Yeah, imaging helps pinpoint which gland is the culprit, especially if surgery is planned. A sestamibi scan is a nuclear medicine test that's really good at highlighting overactive parathyroid tissue, especially adenomas. A simple neck ultrasound can also spot enlarged glands. And a DEXA scan is vital. That measures bone density, so you can see how much bone loss has occurred because of the high PTH.
In treatment, what's the usual approach?
For primary HVT, especially if you have symptoms or complications like kidney stones or significant bone loss, the main treatment is surgery, a parathyroidectomy, basically removing the overactive gland or glands. If they can locate a single adenoma beforehand, they can often do minimally invasive surgery, which is great.
But what if someone can't have surgery or maybe doesn't need it yet? Are there medications?
Yes, there are medical options. Cinacalcet is a drug called a calcimimetic. It basically tricks the calcium-sensing receptor on the parathyroid gland, makes the gland think there's more calcium than there is, so it lowers PTH production. Bisphosphonates are often used to protect the bones, to treat the osteoporosis, and if someone has really, really high calcium, a hypercalcemic crisis, the immediate treatment is lots of IV fluids and often loop diuretics to help the kidneys flush out the calcium.